Hello, everyone. It's me, Michael Anthony Giudicissi, president and co-founder of RPMt. Thank you so much for joining me today on our live stream or at some point in the future on the replay. And we are here to talk about today and demystify two key programs in the landscape of healthcare 2023 and beyond. The first one being RPM, or remote patient monitoring, and the second one being CCM, or chronic care management. I have with me today our guest, Ed Stonebraker, who's the CEO of Coordination Centric. And Coordination Centric is a hardware and software supplier to physician offices, home health agencies, and other entities that implement RPM and CCM programs for their patients. Coordination Centric is a pioneer in the state of Texas in providing RPM services. There's not anyone that I think is more well-positioned to talk about what these programs mean now for our industry and what they could mean in the future. So please join me in welcoming in Ed Stonebraker. Ed, welcome to the broadcast.
Hi, thank you, Michael.
You look fabulous.
Oh, you have low standards.
Yeah. All right. So let's get into it for the people that are with us. We're here to talk about RPM and CCM, remote patient monitoring, chronic care management. A number of people that will watch this may not even know what those programs are. Can you give me a thumbnail sketch of what remote patient monitoring is and what it entails?
Sure. Remote patient monitoring, or also known as remote physiological monitoring, if you want to say a mouthful, basically just a tool, monitors patients that have chronic conditions through the use of remote medical devices such as blood pressure cuffs, scales, glucometers, etc. And then that information feeds up to a medical professional, should be on a daily basis. And Medicare and even many private insurers are allowing for these CPT codes to be billed under the remote patient monitoring services.
Got it. Okay. So there's a use of some technology here. It's not just calling a patient up and getting their vitals, but you've got to have this technology component combined in order to make this a true RPM program, right?
You really do. It needs to be electronically synced is some of the terminology that's been floating around. It's not just calling on up and getting their vital signs for that day. This needs to be objective data that the clinician can rely on, and in that manner, that's an important element. Yeah.
So this patient is monitored in their home setting, and that data is transmitted up to a medical professional. This sounds an awful lot like when I got into home health in the early 2000s. There were these units that you would put into the home for telehealth, and a patient would, or telemonitoring, they would go through a bunch of steps. They might weigh themselves. Is it any different than that?
Well, it's significantly different. We're probably in a third or fourth generation at this point, right? So what really assists the remote patient monitoring program that a provider can onboard is it must be easy for the patient. So you got to eliminate the wires. You really need to either have a automatic on button, if you will, right? Or just one button to push, because you still have considerable coaching that takes place to assist that patient to accurately take readings, et cetera, et cetera.
Okay. So I think the biggest difference, aside from the graduation of technology, is that this is something now that Medicare pays for. And I do remember back in 2002 that the agency I was with, purchased the devices, and we might put them in a patient's home, but we couldn't be reimbursed in any way for those. Is that another key difference?
Well, you do have some states, of course, we're in Texas, love Texas. And you'd even mentioned that we're kind of pioneers. Pioneers get the arrows, by the way, early on with the Medicaid program. And we helped that go through legislation, through a couple of sunsets. But Texas has a wonderful model. Now, their model's a little different because you've got disparate providers involved in that single patient profile, one doing the technical and the other doing the professional. So it's with Medicare, it's the federal program, not a state program, but some states do allow the home health agencies to seek reimbursement under certain guidelines, and there are the CPT codes out there that exist for that billing if you're credentialed appropriately. And yes, the Medicaid program, we're confident that the Texas Medicaid program has provided a really nice model that CMS continues to improve as it's getting closer and closer to the Texas model. So it's that the benefit, though, is now, even if you cannot bill, let's say from a home health standpoint, the benefit of the remote patient monitoring program or the remote physiological monitoring program from CMS is that it can be billed incident to. So there's several vendors that are taking advantage of the way those regulations now read.
Okay.
I hope I answered your question without boring you.
Help people understand what incident to means, please.
Incident to would simply mean that, what's the best way to describe that? That a clinical staff time that is working underneath the billing provider does not have to be the billing provider themselves. So
Understood.
It relaxes the regulatory requirements of that billing provider and kind of takes the cuffs off of him, so he can do more with less, if you will.
Understood. Okay, so that's a thumbnail of remote physiological or remote patient monitoring. Now let's talk about CCM, chronic care management, because chronic care programs have come and gone and have been implemented by different providers, different types of providers over the years. What does CCM entail, and is it almost the same thing as RPM?
Well, now CCM is significantly different. And if you would look at CCM as the umbrella, if you will, because RPM and these other adjunct services that have been added, there's a big piece of legislation that recently came out as they continue to change or adjust the care model from a fee-for-service to a preventative maintenance program, if you will. CCM allows Medicare to reimburse the providers for the provision of coordinating their care services to patients if they have 2 or more chronic conditions. And then there is, even under the CCM umbrella, a provision if a patient only has 1 chronic condition. And chronic care management is based on a calendar month program, tracks the patient's health issues through really a patient-centered care plan. So there is an assessment involved. There's a plan of care involved that has to be reviewed at the provider's discretion, and allows for this non-face-to-face interaction that takes place either in the clinical setting or under the supervision of the physician as it's related to the patient's health. Does that provide a definition of chronic care management that hopefully is easy to
It does. It does. I think my connection got a little wonky there, so I missed a little bit of it, but hopefully everybody else got the balance. So, okay. So can a patient who's receiving chronic care management, we'll call it oversight as well, from a physician, they're in their home, the physician's staff is interacting with them as well as the physician themselves. Can they also be receiving services under the remote physiological monitoring program, or is it a one or the other type situation?
They can receive both. So the terminology is concurrent, right? Or they can receive both of those services concurrently, along with the other CCM programs, whether it be chronic pain management, remote therapeutic monitoring. There's other things that have been added. If we want to go into the weeds, we can discuss a little bit of that later without boring everybody.
Mm-hmm. Okay. All right. So we have an idea of what both programs are. Why now, from CMS, in your view, are they reimbursing providers? In other words, what is the intended outcome of inducing or enticing providers to take part in these programs?
Well, again, you could almost call it a paradigm shift. We like to refer to it a little bit more as a care model shift. Who gets the biggest piece of the checkbook? It's the hospital, right? So we want to take some of that money we're paying to the hospital. Let's get it over to the primary care physician, or those that are providing that primary care, and give them the tools that they need to really get more involved in that patient's day-to-day care to prevent them from going to the more expensive modalities of healthcare, if you will.
Gotcha.
So, and it's not new. It's not new. They have been doing this for a while. It's just, the CMS is cautious, careful. It's a big ship. It moves slowly. You can't steer this stuff fast. So, um, obviously, the pandemic put a put some rocket fuel in the telehealth aspect of it, but they've been going this direction for many years now.
Mhm. Now, you talked about shifting the dollars from that acute care hospital stay towards more of this in-home oversight, chronic care type of management. Is the intent cost savings? Is CMS wanting to save money on this program, or are they wanting to use the same amount of dollars to spread care amongst more patients, or is it something else I've missed?
No, that's an excellent question. Will they see cost savings short term? Likely not. But your cost savings come long term as the physician is more involved with that patient. If you help them to manage their diabetes, how many more amputations might you save in the future? Or how many more ER visits might you save in the future? Through our remote patient monitoring service and the scientific studies that we've done, if you are genuinely concerned about that patient, you keep them adherent to a plan of care, it proves beyond a shadow of a doubt that this process works in preventing unnecessary ER visits and preventing unnecessary hospitalizations. So, does it save money? The savings really is long term as opposed to short term. Short term is just a shift from one provider to the next. Long term is where the benefit is seen.
You've told me this offline in a couple conversations, but if one of our patients were to go into the hospital for an average length hospital stay, what's the dollar amount tied to that? Do we have a national average?
I haven't checked that recently, and of course it varies DRG wise from patient to patient, but it's probably, well, I don't know, and a lot would have changed with in the last 2 years with COVID. It was a standard several years ago when the ACA came out that they would just put $10,000 on each hospital stay. Of course, ACA came out back in 2010, 2011. A lot has happened back since then. So it was considerably north of that. My guess would be at least 15,000 at this point. So
Mhm.
you can take care of a lot of preventative care when discussing numbers like that.
Yeah, it seems like at $15,000, based on what a provider might bill for RPM or CCM, you might be able to oversee 100 patients over the course of a month rather than have one patient in an acute hospital stay for 2 or 3 days. Um,
Yeah, and we know with these patients with chronic conditions, it just aren't going to go away. And if you manage them, keep them out of the hospital, out of the ER, or reduce the number of times that they make that visit, it's far more than the average hospital stay because CHF patients, diabetic patients, these patients that go in, it's far more than just your average.
Understood. Okay. All right, good. So we have a little bit of an overview on the programs, on the why. I come from a home healthcare background. A number of people that might watch this might come from that same in-home care. Is there a preclusion against a home health care or home care agency getting involved in the home? Is there any duplication of services or efforts there, or can home health work hand in hand with an RPM provider or CCM provider?
We've seen wonderful continuity of care with the CCM program when properly used within the home care setting of a home health agency. the home health agency is the perfect provider to be managing this. Now, you cannot bill, a physician cannot bill for chronic care management services if the patient is in a home health setting, right? If you're billing for home health services, you can't bill for chronic care management, but you can bill for remote patient monitoring at the same time that you have home health services ensuing. So it's the home health agency can stay connected to that patient through RPM, remote patient monitoring, during the home event or during their episode, and post episode, if they've got the relationship with the physician and the physician wants to use that agency as the that they will oversee, well, then the agency can slide into the chronic care services or the chronic care management and just allow the physician to use them as their incident to partner.
So and home health agency that's got a patient on an episode. If that episode interrupts some chronic care management, once the patient has been discharged from the home health program, that staff could continue to be an outreach of the physician's office to be able to work with that patient, collect that information. Am I understanding that right?
Yeah, so I mean, without getting into the weeds, but your code's 99457. It's important that you follow the regulations, right? But if you've got a good piece of software and you've got good clinicians that are doing their job and doing the outreach to the patient, you just keep track of that time. You do it on behalf of the physician. You roll that information up to the physician or his usually a PA or a different provider within the physician's office when something happens that needs to be escalated, right? When that care needs to be escalated, and you become that service provider for the physician. The physician bills,
Mhm.
and you would in turn bill the physician.
Got it.
Did I explain that in such
You
a way that
did.
makes
Yeah. Yeah, you did. It strikes me that with remote patient monitoring, which RPMt is representing, and Lauren and I are working with, that you have to have the technology piece, the software, and then there's at least a piece of hardware. There are physicians, though, that are uh, take more of a hands-off approach. I really don't want to do that. I like the idea, but I don't want to be responsible for hardware or software. How do you counteract that if you're a potential provider, if you're a home health agency that sees the value? How is there another way for a physician to get involved without having to do all the work themselves?
For sure, yeah, and that's why CMS made that incident to provision, so another third party could work under the general supervision of the physician, and then that home health agency can they bear the cost of the hardware, but they also have the benefit of staying connected to the patient, and they're they would be billing the physician and receiving their payment from the physician for services provided.
Got it. Okay. All right. Good. So there is an option. I have called on a number of physicians, and the one thing that always strikes me is what I think is the disconnect between how many patients are eligible to be monitored or to be seen via chronic care, and how many patients the physician believes are eligible. And the belief number is almost always significantly lower than what the actual number of patients that could be and could benefit from monitoring. So for RPM, what are the criteria in order for a physician to say, yes, I want to be able to monitor this patient, and yes, I'd like to bill Medicare for it?
Well, that's a great question. So for RPM, the patient must have at least one chronic condition, very low bar. The patient must opt in for the service and can even do so verbally. Now, the definition of the device that gets put in the home, it must meet the definition of a medical device as defined by FDA, and I'll let you go look those up.
Sure.
Right, the service has to be ordered by the physician or another qualified health professional,
Mhm.
and the different codes that get used, and there's several of them. Right, for example, monitoring that patient and getting paid for the hardware, that patient does need to stay adherent to the plan of care. Again, that's a pretty low bar. It's basically a 53% adherence rate, or 16 readings of 30 is how it reads. But it's that particular code gets a little complicated because it's a 30-day period, and that 30-day period moves, right, based on the date of deployment. So you want somebody else doing the math for you and make sure you're billing appropriately as far as those enrollment requirements. Data must be wirelessly synced where it can be evaluated, and the monitoring again can be performed by the physician and his or her staff, or incident to, and just make sure all of these are subject to state laws, right? Because a state program or clinicians, as they follow state requirements, can sometimes be a little bit more restricted. And this is under that patient should have been evaluated at least within the previous 12 months. So it could start at the initial visit, and then you put them on RPM services, or you can put them on RPM services if they've been, if you've billed for an E&M code for the previous 12 months.
Got it. Okay. It seems like CMS is getting more and more involved in this remote delivery of services. There are things coming with pain management and behavioral therapy. Tell us what's coming down the pike that will impact this delivery of care in the home.
Yeah, just real high level. So the legislation that was initiated recently, it was called the Consolidated Appropriations Act, or the CAA, if you want to go look at a really big piece of legislation. But it's allowing for one of the big wins. There was the telehealth. Many of the folks that were providing telehealth, that was going to end. A lot of those provisions were going to end after the public, 151 days after the public health emergency ended. So there was some concern about that. The CAA extended that now to the end of 2024. CMS, as they were evaluating this, there was a lot of concern at the front end as far as fraud being an issue, and they found that it's not the case. It's not the case. Providers were using this exactly as it was designed. So that's the telehealth aspect of the CAA. Remote therapeutic monitoring, they replaced a previous code, added a couple of new codes. Now RTM can also be billed incident to, whereas previously wasn't the case. So remote therapeutic monitoring can be outsourced clinically, if you will. And they added several codes for the RTM, and again, under general supervision for the RTM services. That was a big win. But they've currently limited that to only 2 systems, and that's musculoskeletal as well as the respiratory. But they're watching these codes, and they'll probably add other codes in the future of the RTM portion. Under behavioral, that also they added clinical psychologists, clinical social workers. So they expanded the providers that can take advantage of those particular codes. The new code, it's a G code, pays a little bit more than the old code for each 20 minutes. And again, on many of these, there is an assessment, there is a plan of care. You've got some hoops to jump through as a clinician, but these are things they're typically doing in their practices anyway. Now, one of the new items added this year was pain management, CPM, chronic pain management. And with it being new, there's still some restrictions. This is not something that can be billed incident to. The billing provider must be providing the service themselves. So 2 codes. The second code is unlimited. The first code is your initial 30 minutes for the chronic pain management. And then in unusual circumstances, you might have a PCP that refers to a pain specialist. They could actually both bill for that code in the same month, but that's more of an outlier than it is the norm, right? They don't expect to see multiple providers billing for for these codes. And all of these codes that are under the CCM blanket can be billed concurrently, as we spoke before. So that's a very high level of the items that were introduced or extended through the Consolidated Appropriations Act.
Therapeutic care, pain management, chronic care, remote patient monitoring. It looks like, I mean, suspiciously, like CMS is driving as much care when you add in home health and hospice and non-medical care, that CMS is driving more and more care into the home
Yeah.
for ultimately for cost savings. But do we have studies that show that this is as or more effective than institutional care?
The studies that have been, the scientific studies that have been done that we've been involved in, and we work with a local university, their health science center, as well as their industrial engineering uh, staff, in making sure that you follow all the hoops you got to jump through on creating these studies. We've shown and we've proven that adherence to a plan of care increases when you have additional touches to that patient. And that's even with very difficult patients, because as you deal with certain subsets of the population, they can be very, very difficult to assist them in maintaining an adherence to a plan of care. But we've shown that adherence goes up 10 to 15%, regardless if you're working with what might be seen as a traditionally difficult patient, or if you're working with a patient that is traditionally adherent or compliant to their plan of care. Both increase. So we've been able to show that if with more of these touch points with the patient, it improves their adherence to that plan of care. And fortunately, now CMS has laid the groundwork and given us the tools, given the providers the tools to make sure they're properly reimbursed, as long as they're properly tracking their time to assist that patient.
Mhm. I wonder if I don't know if you have a hard statistic or maybe just kind of a gut feel for this, but how many physicians do you talk to that are doing a lot of this work now in a fashion where they're not tracking it and can't bill for it, but actually doing a significant portion of the work?
Well, we ran into a physician that actually had had their patients. They wouldn't take an appointment from the patient unless the patient brought them their previous blood pressure readings. Blew me away, right? Here, a physician is.
Brought them as in handed them a piece of paper?
They had to do one of two things. You probably are aware physicians still love fax machines. It's like the last industry using fax machines. So the patient would have to fax in their blood pressure readings to the physician, or that patient would have to bring in their documentation of their blood pressure readings to the physician, or because if they didn't, their appointment would be reset to another day. I was completely blown away by that, because I mean, the physician here is going above and beyond to do everything they can to assist that patient, get them involved in understanding how today's behaviors are going to affect tomorrow's readings, right? But yeah, they're missing out. They're leaving dollars all over the place. CMS wants to remunerate them for that, and here they're doing the work and not keeping track of it and not billing for it. So with healthcare, I think there's a statistic that gets thrown out. It's slow to adopt, right? But it's gaining traction, and eventually we'll get to that point where many providers are providing services such as these, because it's again, as we said, the current model is just untenable. But a provider that does this and does it appropriately, they can really extend the boundaries of their practice. They can help assist those that are underserved, and continue to provide even those folks a high level of care.
For my home health friends, I know some of them are probably wondering, wait, under this incident to billing, could we be doing this? And are there home health agencies that have set up shop to do RPM services or programs for their referring physicians? And is that legal? I mean, is there a way to make that work?
Absolutely. Yeah. Now, a little difference there. This is not a referral.
Mhm.
So you do have some legal hoops to step through. That's something that we're not lawyers, right? Again, all of this is for informational and educational purposes only, right? So hopefully you've been entertained a little bit as you listen to us here. But it is it's not a referral. So you are a third party vendor. It's a different contract. Make sure you've got the paper between you and the provider, and that's something we can assist with to give them a baseline that they can then make sure and get the legal uh, get the attorneys involved so that they're doing this in such a way to satisfy all the regulatory.
But a home health could provide this, and if they had 5 referring physicians that all were interested in having their patients monitored outside of a direct referral for home health,
Mhm.
an agency could provide that service if they were set up properly to any of those referring physicians or non-referring physicians if they wanted to. Is that correct?
100%. I mean, if you had 5 referring physicians, it would not be unusual to have 1,000 patients that
Oh, wow.
on your chronic care management program
Mhm.
as you're assisting the physician with that. So yeah, that's not unusual at all.
Well, big opportunity. Um, Crystal ball, 5 years from now, are we still going to be doing this in a similar fashion? Are they going to move more different types of care to this type of remote management?
Yeah, 5 years from now, it'll probably be completely ubiquitous. You'll see because those providers that don't get on the train, right, are going to get run over. So it's get on or get out of the way kind of a thing. And yeah, short answer.
That is a short answer, but I appreciate it. If folks want to find out more about Coordination Centric, of course, we'll put it in the notes for the show, but they can find you at coordinationcentric.com.
Absolutely. Yeah.
That's an easy one.
Yeah, and when we came up with that name, coordination, right? We want to help providers coordinate care. One of the things that our platform does, I'm just going to speak very briefly to this, is it will assist multiple providers as they are managing that single patient. So it does a lot of the things that help you to be efficient, and everyone is held accountable as you start swimming in these new waters.
Mhm. Got it. Okay, great. Ed, I appreciate you coming along. I've taken up enough of your time. You got a company to run. So we'll make sure that all the contact info again is in the show notes. But I hope we get to talk some more about this. Appreciate it. And best of luck going forward. Thank you.
Thank you. Best of luck to you as well. Have a great day. Appreciate everybody that listened.
All right, gang. So that's CCM and RPM, as well as what's coming up in the dynamic changes that affect our healthcare system virtually every day, with some exciting pain management, therapeutic management, great stuff coming. So, if you are a provider, physician, home health, home care agency, or private duty company, and interested maybe in getting more involved in knitting these services into your offerings so that you can offer them to your physicians, please feel free to give us a call. All the information will be below in the show notes. You can call, email, you can go to Coordination Centric's website. Be happy to answer those for you. And we'll see you next time on, I don't even know that we have a name for the show. I'll have to come up with one by then. But thanks so much and have a great day.